Hello, this is Gina Piscatelli with the second lecture on the respiratory system for students taking Anatomy and Physiology 2 at Madison Area Technical College. The topic for this lecture is the mechanisms by which we move air in and out of the lungs, which we call pulmonary ventilation. So we're going to look at how the lungs are ventilated. And there is an animation that you might find helpful on YouTube that I'm showing on this first slide, and it relates the movement of air in and out of the lungs to how the thoracic cavity changes in size. And this change in the size of the thoracic cavity is achieved by muscular contraction for expansion and then relaxation for exhalation. And the muscle that's shown here is the diaphragm, and it's red. So externally we can see the chest change size when we breathe. When we inhale, the chest tends to expand, and when we exhale, it tends to reduce. So as I've defined, ventilation is defined as the movement of air in and out of the lungs, and it consists of two phases. One phase is called inspiration, and that's when air moves into the lungs. The other phase is called expiration, and that's when air moves out of the lungs. So during normal quiet breathing, we perform these two phases approximately 12 to 16 times a minute. So that's a normal breathing rate, 12 to 16 breaths per minute. And each breath consists of both an inspiration phase and an expiration phase. So air moving in and out. Inspiration is considered an active process because muscle contraction is required. Expiration, on the other hand, is passive, and we consider it a passive process because muscular contraction is not required in normal, quiet breathing because the muscles are relaxing and reducing the size of the thoracic cavity. I wish we had more time to talk about the depth of respiration. We'll talk about it a little bit in the next lecture, but we can vary how deep our breath is by changing how much we expand our thoracic cavity. And the degree of expansion will depend on the force of muscle contraction, which in turn is dependent upon the nervous system and how many motor neurons are innervating that muscle. The more motor neurons that stimulate a muscle, the harder it's going to contract, and that will increase the change in the thoracic cavity. So, why does air move in and out when we change the size of the thoracic cavity? It has to do with creating a pressure gradient. So air moves due to a gradient of pressure. Just like everything else we've learned about movement of molecules, movement of fluid, air is going to move from a region of high pressure to a region of low pressure. And the air that we breathe, generally speaking, depending on how elevated you are in terms of mountain ranges, etc., the pressure of our atmosphere is about 760 millimeters of mercury. So if we want to inhale, if we need air to go into the lungs, we need the inside of the lungs to have a lower pressure than that. And when we exhale, we need the pressure inside the lungs to get higher than 760. And that's exactly what happens. So notice the numbers that are shown in this picture on the right. During inspiration, the pressure inside the lungs is 758 millimeters of mercury, which is lower than 760. So air will move down a pressure gradient from high to low and into the lungs. In the diagram on the left showing expiration, you can see that the pressure inside the lungs is 763 millimeters of mercury, and that is higher than atmospheric pressure, which is 760. And so air is going to move from high to low pressure and leave the lungs. So the summary is written down below. Air flows into the lung when pressure in the lung is lower or decreases below atmospheric pressure. And then air will flow out of the lung when the pressure inside the lung is above atmospheric pressure. But then the question becomes, well, how do we change this pressure inside the lungs from inspiration period to expiration phase or period? It has to do with the volume of the thoracic cavity, which I've alluded to previously. So this is how pressure in the lung is changed and why, or why, the reasoning behind it. Changes in pressure occur due to changes in volume. And there is a relationship between volume and pressure of a gas that has been defined as Boyle's law of gases. And what it states is that there's an inverse relationship. When there's more volume for a gas to occupy, more space, the pressure of that gas lowers. When there's less volume for that gas to occupy, or when volume decreases, the pressure of that gas increases. So it's an inverse relationship or inverted relationship. And so when we breathe during inspiration, the thoracic cavity is expanded. That means that we've increased the volume of the thoracic cavity and therefore lowered the pressure of any gas that is inside the thoracic cavity. When we exhale, we reduce the thoracic cavity. Notice it's a smaller size now. And this decrease in volume raises the pressure of any gas that's inside that space. There are muscles involved during quiet normal inspiration. Muscular contraction occurs for inspiration to happen. So inspiration is an active process, always, always. And this is achieved, inspiration, by the diaphragm, which contracts and moves inferiorly, and the external intercostal muscles contracting. And that makes the rib cage kind of swing upward and out. So that's for normal quiet inspiration. That's what makes the thoracic cavity enlarge. During quiet normal expiration, those same muscles relax. So it's a passive process. Muscle contraction is not required. The diaphragm relaxes. That means it moves superiorly. That reduces the space of the thoracic cavity. And the external intercostal muscles relax. And that makes the ribs move kind of downward and inward. Now, one other thing that helps with normal expiration is the elasticity of lung tissue. You might remember from the last lecture that the alveoli of the lung, as well as the pleural membranes, have elastic fibers. And once they've been stretched, then they recoil. So we call that recoil elasticity. And that will help decrease the volume of the lungs. Now, there is an active inspiration process, even though sorry, of course there is, but there's a forced inspiration process where we go beyond normal quiet breathing, and the thoracic cavity expands even more because additional muscles will contract. And those muscles that are involved with increasing the size of the thoracic cavity even more are the scalenes, which generally go from the ribs up to the skull and the neck. The sternocleidomastoid, which you learned in A and P1, which go from the clavicle, the sternum, and up to the skull. And the pectoralis minor, which helps swing the rib cage outward and upward a little bit more. So when those three muscles contribute to inspiration, we call that forced inspiration, and the depth of the breathing will be higher because the size of the thoracic cavity will be expanded even more than in quiet respiration. Now, normally expiration is a passive process during quiet breathing, but we can forcibly exhale as well. And when we do that, now it's an active process. And of course, the passive process is involved always during exhalation. That is, the muscles relax the diaphragm and the external intercostals. But there are some additional muscles that we can contract to force air out even more. And those are the abdominal muscles, specifically the rectus abdominis, and another layer of intercostal muscles called the internal intercostals, which kind of bring the ribs closer together. So that helps force air out of the lungs when these two muscles contract. So I've talked a lot about how we change the volume of the thoracic cavity, but I haven't actually linked that to changing lung volume. And it has to do, and there's a reason, I wanted to introduce it slowly, but lung volume changes with thoracic volume, and that is due to the anatomy that you've learned about a little bit already concerning the lungs, that they're wrapped in pleura, and there's two layers of this pleural membrane, and there's fluid in between those two layers. So recall that the parietal pleura is the outermost layer of the membrane surrounding the lungs, and it adheres to the rib cage, the diaphragm, and the mediastinum. Basically, it's adhering to the thoracic wall. The visceral pleura, in contrast, the second layer, is deeper, and it adheres to the lungs. So you've got this two-layered membrane between the thoracic wall and the outside of the lungs, and they are linked by a space called the intrapleural space in which there's fluid. So there's pleural fluid in between those two pleural layers, but that fluid causes the two layers to cohere. There's a cohesive attraction then between the parietal pleura and the visceral pleura. The fluid allows for the mobility without fracturing the membrane. If it was just one membrane and you tried to move it, it would break. But because of this pleural fluid, it doesn't. So let me show you a picture. It happens to be from a cadaver, the picture that I have. And it is a horizontal or transverse section through the thoracic region. Here's the thoracic vertebrae here. This is the aorta. And what you see on your left side is an intact lung, the way it normally appears. Pretty much, except for right here, adhered to the thoracic wall. But on the right side, we notice that the lung has kind of collapsed. Now this is probably due because to the fact that they dissected this for a picture, but this can also happen in a clinical situation, and it is a problem for breathing. And we'll talk about that later. But the reason they've done this is they wanted to show you, as do I, that the lung is surrounded by visceral pleura. The thoracic wall has the parietal pleura adhered to it, and the fluid is located in the middle where the space is dark. So the pleural fluid makes the two layers of pleura adhere to one another. And so if you get expansion of the thoracic wall, it goes outward, then the lung is going to follow and also expand because of the presence of these two pleural membranes and the pleural fluid. So the summary of pulmonary ventilation is that inspiration requires muscle contraction during normal quiet breathing. It increases the volume of the lungs, and that lowers the pressure in the lungs relative to atmospheric pressure. And so gas will flow into the lungs from high to low pressure. During expiration, the opposite is basically true. We have muscle relaxation and elastic recoil of the lung tissue helps to decrease the size of the lungs or the volume of the lungs, stated here as a decrease in pulmonary volume. When you lower volume, you increase pressure. And so there's an increase in pulmonary pressure relative to atmospheric pressure. So now where is gas going to go? It's going to go into the atmosphere, or if you prefer, out of the lungs. Now there are other factors, physical factors, that affect the degree of ventilation. And when we talk about disorders, we'll talk about how these factors can vary amongst people and their conditions. But these other factors that affect how much air moves in and out of the lungs are airway resistance, also known as friction, alveolar surface tension. That's a little bit more complicated, but it has to do with the fact that alveoli tend to want to collapse unless surfactant is present. And then the third factor is the elasticity of lungs, which we know is really important during exhalation, and lung compliance, which I guess is also due to the elastic fibers, but it's the opposite force, that is distensibility or expansion of the lung, and that's important during inspiration. So normally friction or airway resistance is kept pretty low in a healthy respiratory system due to the fact that airway diameters are quite large and air is not viscous at all. Not as viscous as a fluid, and certainly not, like a gooey fluid. So resistance is usually quite low. That changes with disorders, of course. And we know that alveolar surface tension, the fact that the walls of the alveoli have this cohesive property where they want to collapse on each other, kind of move inward, is kept low by a detergent, basically, of proteins and lipids called surfactant. Elasticity, of course, is usually pretty constant, and so is compliance, and it's always due to, both of those are due to elastic fibers. So I wanted to do just one quick thing for fun here, and that is talk about how we as humans breathe compared to some amphibians. So The ventilation or respiration in humans is often referred to as negative pressure breathing, and that is just referring to inhalation. Negative pressure, meaning pressure below atmosphere, allows us basically to suck in air effortlessly, right? The muscles contract, but the air is drawn in. It's sucked in because a negative pressure is created inside the lungs. Now, frogs, amphibians, they do that as well. Okay, a negative pressure is created when their nostrils are open. They do have nostrils. And the floor of the mouth is lowered because they've increased the volume of their mouth, essentially, and their nasal cavity. So that lowers pressure and air rushes in. So you'll see their throat bulge, right? But that isn't enough for them to get it into the lungs. In addition, they have to apply positive pressure and push the air into their lungs by contracting another muscle that raises the floor of the mouth. And so air gets pushed in. So they use both positive pressure and negative pressure. I just thought that would be kind of interesting to think about. Thank you very much. That's the end of this lecture on pulmonary ventilation.